everyone, welcome. Thank you very much to Joanna Jimenez. She is the chair of the Florida Community Alliance for Angioma Alliance. We just wanted to thank the Florida Community Alliance very much for helping us with this webinar. Welcome to the Atorvastatin clinical trial update webinar. I'm going to hand it over to Joanna now.
Thank you very much, Carla. Hello, everybody. I just would like there's in the bottom of everybody's screen, there's a section that says Q&A. So as the webinar is going on, if you can please post all your questions there, and we will do our best to answer as many as possible. They will be checked at the Q&A and not in the chat section. And in that section, it's also left private, so no one can see the question being asked except for us. I'm going to go ahead and introduce Dr. Awad. He's an internationally recognized leader in neurosurgery. He is skilled in surgical management of neurovascular conditions affecting the brain and spinal cord. He leads the neurovascular surgery program, and he co-leads the stroke and neurovascular care team at the University of Chicago. He is very involved with the Angioma Alliance, and through this trial, he is helping us change the future. So I will now leave it to him to give more information on the trial and an update as well.
Thank you, Joanna, and thank you, Darla, and the Angioma Alliance team. You guys are the engine behind the work and also the motivator, the chief motivators for our work. I want to also welcome my two partners who are joining us in the webinar. Christina Paydad, who is the research nurse, trial nurse for this trial, and Agnieszka Stadnik, who is the research coordinator. Both of them are very involved with screening patients and with the actual mechanisms and engine of the trial, and they will help me field the questions a little bit later. Tonight's webinar will be a little bit different than in the prior ones in a couple of ways. Since some of you have participated in the prior ones and some of you have not, we will give a little overview about the whole trial, but it will not be as detailed as we have done in the past. We want to get to as many questions and answers as possible, because that's really why all of you are joining. And also, we have asked Joanna and her team to screen the questions, so we prioritize the questions that have to do with this trial, because often many of you kind of free-form questions about CCM and pain and associated problems that are very important, but we want to try to get first to the questions related to the trial. So this trial is called the AT-CASH EPOC, AT cash like cash, and EPOC, EPOC trial. What that stands for, it is the Atorvastatin trial for cavernous angiomas with symptomatic hemorrhage. That's what the cash stands for. And EPOC stands for exploratory proof of concept trial. So this type of trial is basically to let us know whether there is a signal benefit effect or a signal risk effect of using the drug that we are testing after there has been a bleed from a cavernous angioma. So people ask, why are we concentrating on the cash cases or on the cases that have had a hemorrhage? Of course, many of us have had a problem with the cavernous angioma because of headaches or because of seizures or because of many other problems, learning disabilities, cognitive issues. And those are all very important. But in order for us to test a drug based on bleeding, then this drug really has to be tested in the cases that are more likely to re-bleed. And we have chosen a group of patients among you who have had a hemorrhage already, and your lesion has not been taken out, and therefore you are living in the fear of a second bleed. And what the drug atorvastatin is designed to do is lessen the likelihood of rebleeding or decrease the likelihood of rebleeding. And that is the goal of the trial. Why atorvastatin? So atorvastatin is one of these cholesterol-lowering drugs that are called statins. And at very high dose, that is possible with only this statin, but not with the others that may be out there. This drug has an effect on stabilizing the blood vessel wall to the point that it inhibits the signals that cause bleeding in cavernous angiomas. And you all may have heard about Rho kinase signaling or ROC activity. That is what causes the blood vessels to leak, and high-dose atorvastatin has been shown to inhibit that leak. We had to do about 10 years worth of work leading to this trial, working first in the mice and also working in human beings to show that, in fact, that dose of statin will have the effect that we want it to have. But what remains to be tested is, does it really do what it's supposed to do, which is decrease rebleeding? So when you come to us with a bleed, you are going to be randomized into either receiving the drug or an identical pill that is a sugar pill that looks like the statin but does not have the statin drug. You will not know if you're receiving the active drug or the placebo, and we will not know if you're receiving the active drug or the placebo. So why is that? People ask, why are you doing that? Why don't you just give me the statin and let's see if it works? So in order to see if it's worked, you have to compare it to something. And just having a bleed rate, lesions will bleed with or without statin. So we will not know if the statin is making a difference unless we compare it to a group that actually is not receiving the statin, but in every other way, it's the same types of patients, same types of bleeds. So we flip the coin and half will get the drug, half will get the placebo. Then people ask also, is it ethical to do this? Why are you giving me the sugar pill? Give me the statin. So it is in fact ethical because we do not know that the statin does not do harm. So when you have a 50% chance of being on the drug or the placebo, you also have 50% chance of being on the better one. We do not know which one is the better one. We will answer that as a result of the trial. So if this trial succeeds, we can tell the world of cavernous angioma if it is worthwhile to take statins and to pursue them for further testing. So the bottle of statin says, take it for cavernous angioma bleed. And wouldn't that be wonderful? On the other hand, if we find that it is harmful, we will warn you not to do it, to stay away from it, not to waste your time with it, and to work on other drugs that are more effective. So we have to start somewhere, and this is where we are starting currently. Another question is, why is this only being done at the University of Chicago? Why can't I go to my doctor in Florida and he gives me the sugar pill or the statin? So the reason for this is because the number of cases we are doing in this trial are not enough to count bleeds, obvious bleeds. In fact, we will not have dozens of cases with bleeds and dozens without. We are going to have a certain number of bleeds and we will compare those, but we are looking at the MRI leakage of the lesion as the primary outcome of this trial. This was a big innovation that the NIH has embraced because it allows us to reach an answer quicker with fewer patients. So if we see a leak on MRI that is worsened by statin, we will tell you not to take statin before we have many people suffer bleeds. And similarly, if we see a benefit, meaning statin is decreasing the leak on MRI, we will try to then move statin along faster than it would before we have many people bleed and counting the bleeds. So this biomarker-driven trial is a big innovation. The NIH and us have a lot of hope in it, because in the future we could compare multiple drugs very quickly with this type of study and be able to choose the best combination for the big trials. The big trials will take hundreds of patients at many centers, and we are getting the other centers ready to be able to do these biomarkers. So we have another study called the CASH Trial Readiness Study, where it is getting multiple sites in New Mexico and San Francisco, at Mayo Clinic, in Utah, all ready to do the next trials similar to what we're doing in University of Chicago. But right now, the validation is only accepted at the University of Chicago, and therefore we will pay for you to come to the visits at the University of Chicago, help you with the travel costs, and help you enroll and get your basic visits with us. The trial requires a lot of screening to know that you are eligible, that you in fact have had a symptomatic hemorrhage, that you are not currently taking statin or have other contraindications like being pregnant or having other problems, liver failures that preclude statin. So we will assess all of these things before we have you schlep over to Chicago. And that is the job of Agnieszka and Christina, who will work with you to gather the data. Then the next question is, if your doctor is in California or in Utah or in even in Canada, that is fine. You can stay with your doctor and we will work with them, and you come to Chicago for only 3 visits: the enrollment and screening visit, the one at 1 year, and the one at 2 years. The trial lasts 2 years, so you have to be committed to taking the drug for 2 years. You cannot be tired and get impatient after 3 weeks and see, does it work on me or not? And we try, if that is going to be the case, to discourage you from being in the trial. So you have to be in there for the duration with a commitment to test whether the drug helps you or not, but it's gonna take the time and the patience for us to get to those results. I want to give you a quick update. The trial was approved by the NIH just about a year ago. So in July of last year is when we received the funding. We had immediate IRB approval for it, Institutional Review Board, which was remarkable, and it's really a great credit to the work that Agnieszka and her team did to have the IRB ready to approve the trial very soon after funding. We had about 2 to 3 month delay due to the drug and placebo manufacture, which we could not start until we received the funding. So ultimately, we enrolled the first patient in the trial in October. So we have been enrolling patients since October. We said that in the first year, we would screen about 100 patients and enroll 27. And we are doing exactly that. So we have so far enrolled 21 patients in the trial in less than 10 months since we started. So we are on track for year 1 to do exactly what we said we would do. This is a lot of work. There is a lot of patients who wish they were part of the trial, wish they could travel and join us. And I am sorry if we cannot get all of you who want to be in the trial, but we try, and we want to try to get as many of you involved. If we move faster than 27 a year, that is great. We will finish the trial earlier and we will have the result earlier. Doing it slower is not an option. We are very doggedly determined to keep moving this on schedule I think we have a lot of help from the Angioma Alliance, from you guys, from word of mouth, from doctors around the country, that I think we're very optimistic that this particular trial will go on to give us the answer, and in the same way pave the road for the other trials with more medications and with broader indication criteria than what we have right now with this first trial. So that is the update. The last update I want to give you is people have asked, well, what has happened to those 20 or so patients that you enrolled? So we said initially that we think about 1 out of 4 will end up not remaining in the trial for varying reasons. And in fact, the numbers that we projected for the trial account for about a 30 to 40% dropout rate for many, many different reasons. So our goal is to stay under that. We have done very well with that. We have had 2 patients lose interest and not follow up. So out of those 21 that said they wanted to be part of the trial, they kind of dropped off the screen. We tried to reach them. They're not sending compliance data, and therefore we stopped sending them drug, and they are out of the trial for lack of compliance. Of the ones who have stayed in the trial, 1 person has dropped out because of side effects. That patient felt that maybe the medications is making him or her feel different than they want to feel. Of course, we do not know if they are even on statin or sugar pill, you know. Maybe they know, but we do not know. But the only choice in that case is for the patient to drop out of the trial. We will continue to follow them with the same way as if they are in the trial by intention to treat. So they were randomized to the trial and dropped out, and we will see what happened to them over the next 2 years. 1 additional patient, and that's the only one in the trial so far, has had a new symptomatic hemorrhage. So that happened while they were in the trial. We do not know if they were on drug or they were on placebo. There will be some bleeds in both groups. That rate has been below the rate that is expected, and we hope that's because the drug is preventing bleeds. So we like that, and for that patient, she ended up having surgery, and we will continue to count her as one who started in the trial. We have not yet had people cross over to change their mind and decide to have surgery, but that is allowed. And if at some point in the trial the patient decides, I want to have surgery instead and my lesion is operable, then they are welcome to do that. Of course, if you know that up front, we don't let you enroll in the trial. But if you don't know that up front, we can start with the trial and then figure out together where we want to go. So I think the trial is going very well. It is exceeding my expectations for a first trial in this disease. And I think we're going to have the answer. What that answer is, I cannot tell you because I don't know. So this is the update I wanted to give. And I think maybe the organizers, if there is any area you think you want to have additional information, otherwise we should go probably to the questions and answers. Joanna, what do you think?
I will begin with the first question. Does insurance status matter? Self-pay, none, Medicaid, Medicare?
Okay, Christina, take it.
And if you are looking to participate in solely the trial, we don't go through your insurance, so there aren't, other than the traveling that you do up front, we don't use your insurance. So basically, you get the MRI and you do all the assessments and screening and exams at no cost to you. And so the type of insurance doesn't matter, again, because we wouldn't use your insurance if you're coming for the trial only.
So let me clarify a little bit of follow-up on that. It is a requirement in the trial that you have medical care.
Right.
So you cannot be uninsured with no doctor. Okay, that's because we cannot have you hanging in the breeze. I can't take care of you because I'm not on your insurance and no one is taking care of you. So we won't know what's happening to you. So you have to have a doctor taking care of your cavernous malformation in order to be part of this trial. So you have to have some form of insurance or other means to get care for your cavernous angioma. It does not have to be by Dr. Awad at the University of Chicago. So if your insurance restricts you, or if you prefer to stay with your doctor at Stanford or at Mayo Clinic or whatever, that's perfectly fine. You come to the University of Chicago, there are no bills to your insurance, there are no bills to you, okay? You incur the costs of travel, but we give you, if you come from outside the Chicago area, a $500 stipend to help with those expenses for each of the visits, or each of the 3 visits. All the MRIs done in Chicago will be free of charge to you. All the blood work we do is free of charge to you, and the drug is free of charge.
Great. Another question. If I had surgery last year, but I have had a new bleed, can I qualify? What if it is in a different or new lesion?
The answer is yes to both. So the only exclusion criteria is that if the lesion that has hemorrhaged has been removed or radiated, okay? So if it has been removed or radiated, then you cannot qualify. But if you bled in a different area, certainly you are eligible even though you had prior surgery.
Okay. Is there a connection between vascular dementia and cavernous angioma?
So I want to discourage questions that are not related to the webinar, but let me answer it. So people who have many lesions in the brain, as they get older, their cognitive challenges become more and more difficult. All of us have cognitive challenges as we get older, but if you have neurologic disease, if you've had brain surgery, if you've had bleeds, or if you have a lot of lesions in your brain, then it can make the aging process more pronounced. So we think that cavernous malformation patients age heavier. You know, they are carrying a heavier burden throughout their life, and that becomes harder and harder as we get older and we get dementia anyway. It's not going to help to have 30 lesions in one's brain and 2 prior brain surgeries.
Okay. I had an elevated CK in the past. Can I have my levels checked at home before making the trip to Chicago?
Yes. So what you would do is you have, first of all, mildly elevated CK can be related to exercise and other factors, and it's not a contraindication. It has to be significantly elevated. So you can contact Christina and tell them what your CK level is, and we'll see if it has been worked up by your doctors. If you have muscle disease, like a myopathy, you cannot participate. If you have liver disease, you cannot participate. But if it is mildly elevated due to exercise, yeah, definitely recheck it, and we'll work with you to tell you if you qualify or not.
Okay. If this trial is successful, will this be a treatment recommended for all individuals with CCMs, whether symptomatic or not, or only in individuals who have had a bleed?
Right. So the trial answers only the question in the trial. It cannot answer general questions that we might have. So yeah, it would make sense that if it is good for the people that bled, it's probably a good thing to take, you know, but that is another question. We're not testing that question. So the only question we will answer in this trial is whether there is a proof of concept that atorvastatin prevents rebleed, or does it harm rebleed? We will have an answer to one of those 2 questions. It will not change the label of the drug likely, unless the results are so compelling that you know, it's so strong that we can go to the FDA and tell them, based on this trial alone, please change the label of the atorvastatin to allow us to use it in cavernous malformation. Otherwise, there will have to be a phase 3 trial at multiple institutions to confirm the label of the drug. That's a natural thing. So this is a phase 1-2 trial, and then the phase 3 trial will be on bleeds in particular.
Okay, regarding bleed, somebody asked, what constitutes a bleed? They asked because they had a recent bleed and it was difficult to detect on the MRI.
Yeah, so that is a big question, especially when you start seeing doctors that don't know cavernous angiomas. They tell you you have bleeding in your brain. And all cavernous angiomas have some bleeding. So a symptomatic hemorrhage requires that you have new symptoms you didn't have before and new blood on the MRI that you didn't have before. So if, let's say, you woke up with new dizziness or new headache, that alone is not a symptomatic hemorrhage unless you get an MRI that also shows new blood. So you have to have those two criteria. The reason we are very strict with this is because the end point is also symptomatic hemorrhage. We want to be sure you don't rebleed. So the definition has to be that. If you just go by the symptoms alone, one day you may be tired, day you may be depressed, and it may or may not be due to the cavernous angioma. And if you treat that, you may not see an effect of the drug.
Another question, doctor. They have an angioma that grew twice the size in the last year. And the question was if if it would shrink, if the clinical trial medication was also supposed to shrink these angiomas.
Right, so it's not designed to shrink, but it's designed to prevent it from further growth. So cavernous angioma that grows is bleeding, you know, it grows by having blood in it, because the cavernous angioma has bleeding. So if we see a cavernous angioma that doubled in size with new symptoms, then that is eligible. It is a symptomatic hemorrhage, okay, because it grew and it has symptoms. But if it only grew without symptoms, it would not be eligible for this trial. Now remember that you have to have the lesion not resected. There are many times when the lesion grows 3 times in size, we don't know that it's not a tumor. We might tell you, just get it out of your head. And I don't want to give you a statin if you could have a tumor in your head. So if we think the lesion is best resected, you should still get it resected. So if a lesion has grown and it's best to take it out, then follow your doctor's advice and take it out. If the doctor is telling you, well, I don't know, it may be risky to take it out in the brainstem, it's deep, etc., then those are the cases that are great for us to consider for the trial.
So another person asked, if you are on statin now, is it possible to stop that in order to join the trial?
Right, so that doesn't work because you have to be off statin for a year. And if you just had the symptomatic hemorrhage and you stopped the statin for a year, you will no longer be eligible because you have to have had the symptomatic hemorrhage within a year to get into the trial. So you have to be off statin for a year or we cannot test the effect of statin. The other thing is it may not be a good idea to stop your statin if you're taking it for your heart or for your cholesterol. We don't want you to have a heart attack by stopping the statin so you can join the trial. So if you're on statin, you're on it, and we'll let you know if it's good for your CCM or not, but you can't help us answer that question. We have to involve the patients who are statin naive in this particular trial.
Great. So when someone asks, are you making a decision to accept a patient who has 1 lesion compared to a patient with 15? Because if you don't get a bleed in either patient, it changes the percentage of results. If you can please elaborate.
Yeah, so we accept patients who have many lesions, but usually only one has had the symptomatic hemorrhage at which we are treating. So within the past year, they have had to have had bleed from one lesion. If they happen to have had symptomatic hemorrhage in the past year in more than one lesion, they're still eligible. So it is okay, but I can tell you that is very rare. Even people with many, many lesions, usually one has caused the symptomatic hemorrhage in the past year. And maybe another one was 2 years ago and got taken out or whatever. So each patient is a little bit different, but very few have had symptomatic hemorrhages from more than one lesion, all symptomatic and all at the same time. But that's okay. If that's the case, we'll test you as well.
Okay. Does this trial take into account whether the CCM is familial or not? Would the results apply to both?
The results will apply to both because of a very, very important research that you may or may not be aware of. So the familial cases, you inherit one copy of the mutation from your parents in every cell in your body, and the second copy happens by chance, and that's why you form a lesion there. Then when you have another chance, you form a second lesion. But already the background has one copy that's bad, and that's why you have maybe 13 or 30 or 40 lesions. The sporadic cases, they have a mutation only in the lesion. So the chance of that happening many times is rare. So most of you who have sporadic disease have only one lesion, unless you have 2 or 3 with the vein, with a venous anomaly, that's still called sporadic. So the good news is that both types, the sporadic and the familial, have problems with the same molecular triggers. So the same genetic problem is happening in the lesion, whether you have the familial form or not. So we have made a very strong case for the drug that works in familial cases will also work in the non-familial cases as far as bleeding is concerned and growth. Of course, if a drug is being taken to prevent lesions from forming, like there may be another drug one day that we take to prevent lesions from forming, that will only apply to the familial cases.
Okay. Dr. What dose of statin are you administering in the trial?
Sorry, what's the question?
Dose.
What dose? So the dose that causes the ROCK inhibition is Atorvastatin 80 milligrams. So this is the high dose approved by the FDA for stroke prevention and for very bad heart disease. So if you have a stroke today from another cause and the doctor is prescribing statin, they will automatically go to Lipitor 80 or Atorvastatin 80. So that is the dose that we are testing. If you have side effects on that dose, like tiredness, muscle fatigue, etc., we will cut it in half and give you half the dose, knowing that it will be a weaker ROCK effect, but at least maybe better than nothing, and we will check that. We don't know how many patients will end up having the low dose, but that is an option to keep you in the trial and maybe get some benefit from the lower dose, better than nothing. But if possible, we want you to take the dose that we know does what we want it to do.
Okay. Somebody else asked, which I think you almost answered, how would the atorvastatin help with bleeds?
Yeah, so it stabilizes the barrier between endothelial cells. So the blood vessels are lined by endothelial cells, and cavernous angiomas have only endothelial cells. So if those endothelial cells are leaky, you bleed. So if we make the endothelial cells less leaky, you are less likely to bleed. And that is the effect that we are testing.
Okay. This dosage for the trial for both children and adults, the dosage could be different. If you can please explain.
Agnieszka, want to take this one?
Yes, absolutely. Hi, everyone. So children are not allowed in the study, unfortunately. You have to be at least 18 years old to be enrolled in the study. So the dosage for children does not matter in this trial.
So the reason for this is that the FDA has a totally different process of approving drug in children, and atorvastatin at this dose has not been tested for stroke prevention and cholesterol lowering in children, obviously because children don't have a lot of strokes and don't have cholesterol problems yet, unless they eat a lot at McDonald's. But in general, statins are not used in children, so we could not make the case to the FDA to allow us to test children based on the safety of statins. So for this drug, we went through a fast pathway to do it. We didn't have to retest the drug to make sure it is safe in general in the population, because it's already safe in general in the population. This will not be the case when we develop new drugs called X, A, B, or whatever. Those drugs have to be given to normal patients to make sure they don't grow horns or drop their limbs when they take it, okay? So we know that doesn't happen with statins. That's why they allow us to use it. And that's a great case for repurposing drugs that are already approved. But the case will be made in children very quickly if we have an effect in adults. So the FDA listens, and if we have an effect in adults, I have no question in my mind that we'll be able to extend it to children.
Right. Is a lesion the same as a cavernous malformation?
Yes.
Okay. If we believe we may qualify, what is the process to request consideration?
Christina, take that.
So I believe in one of your reminder emails for the webinar, there should be a link to our trial brochure. That brochure has all the general information about the trial along with the contact information. So the main person is myself. I have a study phone that you can call at any time with questions, and there's a designated email address that you can email me, and then I will initiate the screening process from there.
Don't do it at 1 a.m. for Christina unless you have to. So you will get an answer within a day, basically, if you get voicemail on the phone, unless it's an emergency. But the fact of the matter, very easy access, email us, call us, and then you'll get an answer right away, and we'll start engaging you in the question answer about your eligibility.
One more question is, are there...
Joanna, that brochure will also go out in your post-webinar email, so you should get that again.
Okay. Are there specific questions that should be asked to see to people who have had a recent bleed to help the screening or enrollment process?
Yes. So I think the first question you asked, did I have new symptoms? And did the doctor do MRI that showed new blood? Now, sometimes there may be a misunderstanding. You may think the doctor told you that, and we will check that. We will check that. We don't take anybody's word. We will want the images. We will look at the images, and we can explain to you that, look, what the doctor told you, maybe you misunderstood. You didn't really have new bleeding. You may have had a seizure or a migraine exacerbation or a bad day or something, but it wasn't a new bleed, and therefore we cannot consider you based on that. But most people are really smart enough. They already know that they had the new symptoms with new blood, especially with the patient who didn't know they even had a cavernous angioma, right? So their first symptom is they have a bad headache, or their face is weak, or they have double vision, and then they are told they have a cavernous angioma with new blood. So you immediately qualify.
Perfect. What kind of research and trials can we expect in the near future?
Yeah, so there are many, many fronts that we are working on. This is only the beginning, but we have to do what we say we're doing. Otherwise, nobody will trust us with bigger trials. Not the drug companies, not the venture capitalists developing drugs. So I think this community has been phenomenal in terms of embracing the culture of research. And this is a big feather in our hat. But basically, The second thing we are doing in parallel is testing many other drugs in mice, the way we did statin the last 5 to 10 years. So it always has to work in the mice before anybody gives you money to try it in humans. So just because you think it works in humans, nobody's gonna spend $10 million just because you think that. So they wanna see some evidence that you can hang your hat on it, you know? And this is why we are sometimes so strict. People say, give us a break. Why are you so strict, you know? Let us try it in other forms of the disease. Yeah, that's true, but you know, we received almost $10 million from the NIH to do this, and they would not have given the money if we didn't have very specific steps that we could answer. So what we're trying to do now is test other drugs. Propranolol, for example, that many people have questions about, is already another drug that's very widely approved and used. We don't know if it really works or if it's just an anecdotal evidence. So we're trying it in the mice. If it shows benefit in the mice, we will make the case to do with propranolol what we're doing now with statin, whether we do it in parallel at a different group of centers or whether we do it after statin enrollment finishes, that, which we are, you know, in another 6 months, we'll be halfway through enrolling for this trial. So we'll be ready for the next good drug. There are other new drugs being developed. There is the drug Tempol by Recursion Pharmaceutical. It's now going through its safety use as a first drug in man. So before it touches a cavernous angioma patient, they have to go through other steps. But then it may be used for new lesion formation. It may be used for a combination endpoint of headache, seizures, and bleeds, not just bleeds. So that's up to Recursion Pharmaceutical, who is funding it, to try to see what they want to do. But it may be a trial that is more open for more patients at more sites, and that will be great. There is also a project called Trial Readiness that is funded by the NIH, and that is validating the biomarkers that we are using on MRI in Chicago so that they can be used whether you enroll at Mayo Clinic or San Francisco or New Mexico, etc. That will be a great advance because patients don't have to travel to Chicago to get the trials. So the trials will be much more efficient in that regard. And finally, what we are also doing is working very hard on blood biomarkers. Many of you know that we are doing a lot of tests with the blood to see who has bled and who will bleed again based on your blood test. Because if we have an accurate test that does that, then that will help us select more of you to participate in the trials. You could say, as long as your blood test shows that, you are welcome to be in the trial. So all of those things are happening in the background, just as we are doing the AdCash epoch.
Doctor, are there limitations for post-menopaused women to be included in the study?
No.
Okay. As you are looking at other repurposing drugs, have you looked at drugs to lower blood pressure? Also, are you backing your study data with artificial intelligence to review all the patient data as you build your trial?
Yeah, so artificial intelligence has to depend on reliable data. So far, the registries have been very poor. Even lesion counts in the registries is inaccurate when it is audited. You know, people say, well, I have 10 lesions and I count them and they have 13, you know. And so it is, we have to harmonize a little bit the data elements that count, and that is what the Trial Readiness project is going to do, is teaching many centers to measure exactly the same way, including quality of life. We can't measure quality of life differently on the East Coast than the West Coast and then expect artificial intelligence to sort that out. So we are harmonizing the data first. Then where artificial intelligence is helping us now is in optimizing the biomarkers. So those blood tests include many molecules that could have signals from the cavernous angioma. And we are using very exciting machine learning methods to tell us that the best blood test is a pattern of these different molecules that actually artificial intelligence discovers. So it's a very exciting time. It's not your grandfather's blood test. These are very new blood tests that are based on very advanced machine learning methods.
Okay, doctor, somebody writes, our daughter has 162 cavernous angiomas in her brain. We are looking for reduction in lesion size. Is there anything coming up?
Yeah, so the best thing we can say right now, a drug that may help with lesion burden and with chronic disease aggressiveness is vitamin D. It works as an anti-inflammatory drug because a vitamin D deficiency makes you pro-inflammatory and your disease is more aggressive. People have more lesions and more bleeds when they are vitamin D deficient. We have not tested vitamin D against the placebo, so we do not know if you can correct this by taking more vitamin D. It may be just a signal. Those who are weak with vitamin D are more pro-inflammatory, and you can never fight it off by taking more vitamin D. We don't know. But I would, in my practice, I recommend that people take vitamin D. We do not have another drug that is particularly designed to eliminate lesions or prevent lesions from forming. That's the next frontier.
Okay. And the final question was, who is the contact person to reach? And I guess it's Christina. If you can please put your email or phone number. They would like to get more information about the trial.
It's on the brochure that you're receiving at the end of the webinar, and you received the link to it before the webinar. So it's got all our contacts.
Perfect. We answered all the questions. We've been doing this webinar on a quarterly basis to give an update and inform anybody in the community that wants to know more. So please make sure to tune in again in the fall. I have one more question that just popped up, and I guess you can answer it.
Sure.
What dose of vitamin E is recommended?
Well, it's not vitamin E, it's vitamin D.
Vitamin D.
D.
Yeah, they wrote E, but it's D.
Okay, so vitamin E actually can cause more bleeding, so we don't recommend vitamin E. So vitamin D is the drug that is anti-inflammatory. It is a drug that has been shown in mice to help cavernous malformation, formation, and bleeding. And the dose that we recommend is what you can take at the pharmacy over the counter, between 3,000 and 5,000 for adults is the dose that we recommend. If you are in doubt as to how much you're taking, ask your doctor to check your vitamin D level. And if the vitamin D level is below 25, they call you vitamin D deficient, and therefore you need to take more. If you already have a level of 40, you probably cannot make it better by taking more vitamin D.
Okay.
So the level will be, the level that we found makes a difference in disease aggressiveness is the level at which you are deficient in vitamin D, which is level of 25 in your blood.
And a few more questions came in.
Sure.
What about magnesium? Magnesium, oh, I can't pronounce it.
Yeah, there is no information on whether it helps or it hurts. So whenever we have something that we don't know whether it helps or it hurts, I say stay away from it because it may be harmful. For all the good reasons you think it may help you, it may actually do the opposite. The same we have found with things like taking Botox. People think it helped my migraine. We have had now cases where people have bled after Botox, and we're going to report that. People who take probiotics thinking they're improving their microbiome. We have had dozens of bleeds immediately within the time that people started taking probiotics. So you think you're helping yourself? Our recommendation is stay healthy with your microbiome until we tell you how it is best to change it. because if you change the microbiome in the opposite direction, you may be doing a lot of harm without knowing it. So the same applies to all these supplements that, you know, my neighbor told me is great. I just tell people stay away from it, because unless we know that it's safe, it could have a combination of effects that harm us.
Okay. One more question. As a lesion is a blood clot lesion, is it susceptible to plaque, as in the vascular system, veins, etc.? Can plaque build up in the lesion? So is that the premise of the statin?
No. So the plaque builds up in arteries, not in veins. So the plaque is an atheromatous disease that builds up in arteries. What we are seeing in cavernous malformation is really leaky capillaries, dilated capillaries, which are the tiniest blood vessels. They're not the ones that have plaques. However, what statin does to plaques, it also does to cavernous angioma. It inhibits the inflammation and the leak, which is bad in plaques and bad in cavernous angiomas. So there is something in common to that effect, but that doesn't mean you have a plaque in your cavernous angioma.
Thank you, Doc. Should I get stereostatic surgery to get the lesions removed?
Should we get what, sorry?
They put stereostatic surgery.
Can you spell that?
Stereostatic surgery was what they wrote, but
Stereotactic surgery?
yeah, probably what it is.
Yeah, but stereotactic radiosurgery does not remove the lesion, it just radiates it. And the recommendations currently are to only consider that very, very carefully. So I would refer people to the guidelines on CCM, which are also listed on the Angioma Alliance website. And there is some very specific discussion of stereotactic radiosurgery and its role. That's really outside what we're talking about today. I don't want to just get in a very shallow answer that doesn't really fulfill that. Now, stereotactic technique for resection of the lesion is used all the time. So we never go in to remove a lesion without using stereotactic image guidance. That's different from stereotactic radiosurgery. So the decision here is not about stereotactic, because it sounds like it's a great word. It's about, if you're going to remove the lesion, then the doctors will use these advanced methods to help you with removing it.
Okay. If you are pregnant, is there a limit to the amount of vitamin D you can take?
I would ask your obstetrician. Normally, the obstetric practice is to make sure you are not vitamin D deficient, because that's bad for you and the baby. So maybe I wouldn't like stuff hundreds of units of vitamin D. If you're pregnant, I would check vitamin D level and only treat in pregnancy if you're deficient, just in case the excess of vitamin D can do harm to the fetus. We do not know.
Okay, I have AVMs as well as angiomas. Will the study affect my AVMs?
No.
Okay.
They are a totally different disease with the effect of statin has never been tested in AVMs, so it will not be relevant to AVMs.
I guess someone mentioned that they had pain, and when they went to their doctor, they told them that there wasn't a real purpose to have an MRI, that they wanted your opinion on that.
Yeah, so if it's a new headache and you know you have a cavernous angioma, it is probably prudent to get a repeat MRI, because the bleed can only manifest itself as a new headache, as many of you know. Sometimes you had a very horrible, different headache from anything you had before, or pain in the back of the neck or in the low back, and that turned out to be a cavernous angioma bleed. So if you know you have a cavernous angioma and there is pain related to where that lesion is, then I would certainly pursue an MRI in general to be safe.
Okay. Doctor, that was it for questions, and thank you so much for these webinars. Somebody says you are always telling us things that help us, so informational, and I agree. This has been very, very helpful for everybody that's here. I will be doing it one again come the fall, so we'll get an update on the trial, and we'll be able to ask more questions to Dr. Awad.
Thank you, everybody. This is a team effort. We cannot do it without all of us working together. And I want to thank everybody involved.
Thank you.
Absolutely. Thank you, Joanna, and thank you, Dr. Awad, and your team.
Thank you, guys.